Okay. Okay, so good afternoon.
Good afternoon.
Hello. Can you hear me?
Yeah, we can hear you. This is Ramesh
I can't
Dagubati.
hear. Okay.
I'm with Dr. Madheshwaran.
Oh, hi Ramesh. How are you?
Very good. How are you?
Okay.
So, yeah, please go ahead and
Yes, we are doing fine.
thank you very much for doing this 13th live case for NIC CSI midterm meeting.
Okay, it's a pleasure. It's a real honor to be asked by NIC to do a case. And were you there yesterday during the NIC, when the NIC data were read out?
Yes.
So 3,87,000 angioplasties and 13,000 CTOs.
Right.
So that was the data from NIC that I had.
That's
Of which, so that comes to around 0.3% of our all cases CTOs, and of them 97% were antigrade, so 3% retrograde,
Yeah.
which is 0.0001. So not 0.3, 0.03, and then 0.0001. That is the data from NIC. So I didn't have in mind to do a CTO because CTO doing live is always a little hazardous. But I chose an easy case, so it is a CTO, and I'm going to just present the case for you. And I'm just going to show you the steps, and maybe we can discuss what we have learned over the years about how to do CTOs and minimize our failures. So can I see the slides? Can I see the slides? So my patient is a 65 years old male. He's diabetic, hypertensive, non-smoker. He has effort angina class 3 despite optimal anti-anginal therapy. His weight is 62 kgs, height 152 centimeters, and that is the ECG. So you can see it's a normal ECG. Next slide. Next slide, please. And these are 4 cross sections of the echocardiogram. So you can see that the LV function is really very good. No RWMA, and these are his lab parameters. They are unremarkable, so I'm going to go to the next slide. And this is the angiogram. So these are some still pictures. We are going to shortly show you the live pictures. So you can see that the LAD is occluded proximally. The circ is non-dominant, and some more views. Next slide. And there, and you can see that there is a septal branch that is coming off just at the site of the occlusion. And next slide. And this is the still of the right, which shows a 50 to 60% proximal stenosis, and it shows really very good distal, very good retrograde collateralization. So, any questions here?
Yeah, I think this is a very good setup of a nice antigrade CTO approach, in my opinion. But I think, the retrograde collaterals are so good that some people might feel, why not proceed with the retrograde approach itself. So I don't know how many people would in the audience would think it is a retrograde patient in this case. But I would ask Dr. Madheshwaran, what do you think?
We try antigrade first. If it fails, then probably retrograde.
Right.
And this is a very short segment,
Okay.
right? It's
So,
probably less than 15 millimeters in length.
It is. I'll exactly show you what's the length of the segment.
Okay.
So can we go to the first? So while we were waiting, we had done a bit of the case. So I'm going to show you. Okay, just show us. Don't. Okay, one after that. Show us the simultaneous injection. Okay. So we took simultaneous injection from multiple views, and really we are looking at 2 things. One is what is the length of the CTO, and the other is where is the nipple. And I think this view shows quite well that the nipple is just situated above the site of origin of the septal. And then I would say the length of the CTO is around 15 millimeters. Would you agree?
Yeah, I definitely.
Okay. So next slide, please. And I've taken some other views, and it is just to show that which way our wire should go. So when I am doing the wiring, obviously I would just give right coronary injections, and I just want to see the track. And I expect this to be a straightish segment because this is quite proximal in the LAD. So I don't expect too much bends or curves like you could have if it was in the mid LAD. So next one.
So can you tell us about your approach,
And,
transradial, transfemoral, anticoagulation and all of that?
We are doing it transfemorally. And we have loaded the patient with ticagrelor and aspirin. We have given the patient 5,000 heparin. We have done both groin punctures, and we have taken a 7 French guide. And next slide, next run. And so this is the view that I decide. So there are two things. One is you have to go into the LAD, and then what you hope is that you lodge your microcatheter just at that nipple there, after which advancing the wire becomes much easier. So next one. So this is a Asahi Sion blue wire. So you could see that there is a bit of an angle of the takeoff of the LAD, and I use this wire to go into the LAD. And next one. And over that I advance the next one. Advance the microcatheter, and see the microcatheter is just lodged there. It just goes and lodges there. It doesn't go into the septal. The wire didn't go into the septal. And show the next view. And I took this view, and I was very happy with this. See, it is above the septal.
Right.
So I know that I am just in the right place to take a stiffer wire, and so I took a Fielder XTA. Next one. And this is what happened. So we were trying to see what happens is, as I try to advance it, the microcatheter just falls back a little bit. So there is some resistance there. And here there is, I see that the wire bends up a little bit and looks upwards. So I don't like that. So next one, please. So I try again, and I guide it with retrograde injection, and it appears to me maybe I am more or less in the track. And next one, please. And so I advance the microcatheter a little bit, and it is not exactly going where I want it to go. But I just advance it gently, and I try again, and I think that it is a little higher than what it looked. So I take the wire a little bit, and here I take a shot. Okay. So next one, and here I take a shot. I think I'm towards the septal, but see, it is not in the right place. So I come back again and show us the next one. So I come back and I try again. And I have to just point it a little upwards. There. See, there. And there again it is bending, but I straighten it up, and see, there is a bend there, and it just there. It slides over the bend like that, and it goes into the LAD. So next one, please. And then we take a picture, and we can see that we are in the lumen. So any comments up till now?
So yeah, yesterday in the data, NIC data also, we saw that even though, as you said, the percentage of CTOs is lower, but the usage of microcatheters was almost, I think, 70%, if I'm not mistaken. And so what I think that
70,
is a great...
Yes, 66%.
Yeah. So I think it's a great way of showing how a microcatheter has been used here to lodge it in the proximal cap and then proceed it with a stiffer wire. What type of microcatheter is this?
Yeah. This is a fine cross.
Fine cross, right. It's a definitely a low profile microcatheter that has been used here. So people probably would say that maybe you need to take two views, but if the wire is moving freely in the vessel and it is going to the branches.
We have taken more views. So show us the next view. Yeah. One more. Yeah. And the next one, please. Next one. So here the catheter. And next one. Okay.
Yeah.
So you're happy about that?
Very happy. The tip of the wire is very well in
So
the
after
LED.
that so after that we advance the microcatheter, and you can see that there is a little bump where that distal cap is. So watch that again. There. And I must say that this is not the most difficult CTO, but it is a CTO. So I think the steps are important, and when we started doing CTOs, we had no clue how to do it. We didn't use microcatheters that much. We tried it with a balloon, and the wires we didn't know what to use. We didn't know about tapered tip wires and wires with higher tip loads. So that we have all learned from the CTO experts, and that is how we do it. So now I will change it to a Xeon blue wire, which is next slide, next one. So that is lodged there, and then next one, and next one. Show us the next one. Yeah, so that's the wire going in. Next one. And then we take the microcatheter out by inflating an indeflator at the end of the microcatheter, and the microcatheter just backs out. So that is how it is after the passage of the wire. And then we have done a couple of dilatations, and I'm going to show you the picture now, how it looks. So we are going on live now.
Which wire using?
Xeon blue is a very
Okay,
nice soft
can you get the
wire.
hands out of the way, please? So yeah, no, so my wire was a Fielder XTA. I feel comfortable with this wire, and if the distal cap caused problems, I would have changed to a slightly stiffer wire. My choice would have been a Gaia 2. So I'm going to show you how it looks now. So we have done a 1.5 and 2.5 dilatation, and you can see that the flow distally is still not good. So there is still retrograde flow.
Yes.
So once we take care of this lesion properly, then the whole antigrade flow will be restored. So what do you want us to do now? Do you want to see IVUS, or shall we go ahead and stent?
No,
And if we stent, then from where to where?
yeah, I think IVUS is a good way of assessing the size of the vessel, as well as what is the length of the disease.
Okay. Okay, we'll do IVUS. So if you can focus here, can you see? So we are using a Polaris catheter. So while we are setting it up, you could do some discussion.
Yeah, no, I think
And,
you have demonstrated excellently how CTO can be simplified by using certain equipment and dual injection. So in the beginning, I mean, pretty much I know some of us remember how we used to tackle CTOs is not the same as we do nowadays. And even though we might think that this is a simple
right.
CTO, you still, by doing dual injections, we can minimize the amount of contrast. We can actually see how and where the vessel, the proximal and distal cap are. And we can assess by that how to approach the CTOs easily. And also by using microcatheters and equipment
I agree.
and rapidly changing from antigrade to retrograde approaches, we are able to shorten the time that we do nowadays for CTO PCI. You agree with that?
Yes, yes.
Yeah.
I totally agree. I totally agree. Yeah, and also the exchange of wires. So upgradation of the wires. Sometimes the Fielder wires, they're very good at tracking the microchannels, but at the distal cap, they don't have enough. They don't have enough tip load to puncture the distal cap. So if you have a microcatheter, it's very easy. And connection দিয়েছে? So we are just waiting for IVAS to come in. Yeah. So can you see the IVAS images?
Not yet.
Not yet.
Ramesh,
No, we cannot see
ask them to show the IVAS images.
Yeah, we
You are
can.
supposed to.
Can you put the IVAS on the big screen?
Can you see it now? Okay.
Please put the IVAS on the big screen.
So
Okay, very good.
okay.
Thanks.
So I'm going to show you. I'm going to show you just if you can show us. So where it is. So it is beyond that distal 40% lesion. The probe is there, and I'm going to do a pullback now. So press the pullback button, and you should be able to see it. So as we are coming up, maybe you should see both the IVAS screen, how the catheter is coming back, and then you can correlate a little better. So otherwise, I'll give you a commentary. We are not yet at the CTO, so we are coming back slowly.
Yeah, show us the angio as well, please.
Yeah, show the angio. क्या हुआ? Okay. So, পুলব্যাকটা থেমে গেছে রে? হ্যাঁ? Okay. Just wait a second.
From what we can see, the distal reference
back.
diameter here, it appears to be about 3 millimeters in size. And there's still a little bit of plaque. And here you can see some positive
So
remodeling.
we have done around 10 millimeters. Okay, so we are having some problem with the pullback, so I'm going to show you manually. All right, so go to the IVAS, go to the IVAS. Yeah, so I'm just going to give you a commentary on where the tip of the catheter is. So this is right at the CTO, where we had done some dilatation. And that's the distal cap, and then I'll pull back, and you can see the vessel really grows there. You can see a lot of fibrosis there. This is also part of the CTO, where we have made a channel by going in with a balloon. And there is the end of the CTO, and now I'm coming into the proximal LAD. And if you remember, there was disease in the proximal LAD as well. And we want to stent that portion as well. So now I've come into the left main. So the left main is free of disease. And so I would stent from that distal part of that LAD right up to the ostium.
So
would you agree with that, or?
You know, I agree, but then it makes a difference. What size stent would you choose? If you choose a 3/0 stent, you may not be able to post-dilate it to 4.5 in the proximal part.
Yeah, I would settle with 4, I think.
Yeah.
Can you show the proximal part? Can you show just before the? No. Just scroll it to the proximal LAD and do a measurement.
What is it? 3 can be dilated up to 4.5.
Okay. Stop there. Stop. No, maybe bit more. Okay, stop there. Okay, so I would have to land my stent here. See, there. And I agree that it is there is a lot of remodeling there, and it looks like 4.5. But most of these cases, if you dilate with a 4.0 balloon, then you get good apposition, because there is a lot of plaque burden there. So it's not like that it is just lumen there. It is media to media, it is very large. But if you calculate the lumen and the plaque burden, you will see that a 4 would be sufficient. So what is your comment on that?
Yeah, that's it. For well apposition, I think, obviously, minimal stent area will be large enough, even if you post-dilate with a 4.0, but there will be some unopposed stent segments in that area. So let's see, I think 3.0 and going back to 4.0 is not a bad idea. So while you're doing that, we'll go to the other center and we'll come back to you. Is that okay?
Yeah, that is fine. Okay. Thank you very much.
Thank you. We'll be back. Let's switch to Kolkata, please.
Okay.
Yeah, we have 1 minute.
Are you with us, Ramesh?
Yeah, we are back with you for 1 minute if you don't mind.
Okay. Okay, just show them the final angiogram. So we have taken a 3.5 by 48 millimeter stent, and we have deployed it like that. Okay, show the final after post dilatation, and if we have time, we are going to show you the IVUS. Okay, so just show the final, please. This is a 3.5 millimeter balloon, and we have dilated it up and down, and tarpore aro ache na? Okay, this is it. Okay, so you can see last one. So there is a little bit of underdilated stent segments exactly where that septal is coming, and if you remember, that is where the distal cap was. So we haven't been too aggressive. We have just dilated it to 14 atmospheres with a 3.5 millimeter balloon there. I'm going to take back the IVUS, and since we don't have a lot of time, I'm going to do a manual pullback. And if you, I want you to see both, So that is the distal, I'm lodged just beyond the stent, and I have not dilated the distal 4 millimeters of the stent. Because this is a 3.5 millimeter balloon, I deployed it only at 7 atmospheres, and I have done post-dilatation only of the proximal part. I'll do the IVUS, I'll see what it looks like, and then I will decide on choosing a balloon to dilate it. So here goes. So I'm just pulling it back, and you're in the distal segment, just entered into the distal segment. You can see that there is good apposition, but we can stretch it up a little bit more. So we can. So that's what we are going to do. And this is the segment from which we have really stretched it up with a 3.5 millimeter balloon. And you can see that good lumen area there. And as we are coming up, this is the area where the CTO is. CTO was.
Right.
And invariably, this part, it is always a little underexpanded, but I am quite confident that I can go back and take it up to higher pressures, having seen this IVUS. And this was what you were worried about, Ramesh, that what would happen to the proximal segment. Yeah. And see, we have dilated this with a 3.5 balloon to 20 atmospheres. So in the proximal segment. And you can see that there is good apposition. There is no malapposition. I'm going just withdrawing it slowly all the way up, and maybe we can, this last few millimeters, we can go up with a 4 millimeter balloon, just here. Yeah. And there we are just in the left main. Okay? So that was the IVUS, and if you...
Dr. Bhattacharya, I agree with you, that's excellent. I think it requires a little bit of post-dilatation and the distal segment and the CTO part, but the proximal part looks really great. So thank you very much. I really appreciate you, Dr. Bhattacharya, and your team to show this fantastic CTO, which you made it look very simple by using microcatheter and a wire. And I really congratulate your team for such a good procedure done safely. Thank you.
Thank you very much. Thank you very much.
Yeah, with that, we close this session. And